Good morning, everyone, bright and early. We start getting ready for our 19th symposium, which started yesterday with the endovascular. And today our structural and coronary, we are combined both in one day, little extra 1 hour. So you see, instead of 5, we end at 6. And tomorrow will be the NUSTEC symposium. As we've shown in the great video, very good presentation. I mean, of course, we keep getting better. Always say that how do you improve? Whom do you compete? You compete with yourself to get better every year. And this is our now, the 19th, and focus will be exactly what has been said, the complex cases and how can do safely and show all the tips and tricks. With that note, I'll ask Dr. Anpurna Kini, she's the director of the symposium, to make some comment, and then we'll go on with our life because she has to go up and get ready with the cases.
Good morning, and I would like to welcome all the faculty as well as the audience who are here. I think just want to, like we just mentioned on the video and what just Dr. Sharma said, that we compete among ourselves, that we want to be better and better every year. So through the day, we have structural cases as well as coronary cases, focusing on left main disease, calcific disease, bifurcation disease, as well as all the aortic valve structural case, as well as septal ablation. So I hope you guys stay here and learn from us how to do this, I would say, complex case in a simple way. Thank you.
All right. So with that note, I really also thank my national and international faculty who has traveled and be part of it. And little incentive for the evening. At 6 o'clock, we have a raffle. I think it's iPad, the main iPad, not the mini. So those who are staying, we will take the raffle out and somebody will go home with the iPad, big, I think 32 gigabyte. But saying aside that, I really thank my cath lab team, that what we have grown to at present, the leader in the safety as well as the volume of interventional cardiology. So as usual, as every year, we are going to go through the advances which really shaped the field of interventional cardiology in 2015. Some people say, well, it's 15 may be old news, but that may be. But that's the way we have kept our tradition. And I will go in about next 20, 25 minutes about what I feel which really have changed our field. And of course, goes with the Andreas Grundtvig, with father of angioplasty. The dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patients. And we know now that almost 65% of the tower are being done without intubation. And I added my code with utmost safety. And the advances are picked up from various journals and the presentations. And the idea there is that they've changed our clinical practice. So starting with the first one, the CTO trials, and particularly the CTO advances. We know that Japanese are the leader in the world for the CTO. And but where we are as a country, United States, we have the data from the National Cardiovascular Registry that our success rate as of 2013, about 60-62%. And I'll give you the data of the even later from the CTO trial. And of course, only problem is that very small percent of the PCIs are being done as a CTO. Is the 5% right number? Probably 8 to 10%, because the volume of the CTO is dependent or determines success and decreasing complications. So higher volume you do, lower will be the complication and better the success. We have some glimpse to it, that expert CTO trial of 250 patients. So what we learned in the United States in 2014 and 15, that our success rate is also about 90%. So we really have gone up in the CTO arena, United States, and these are the expert 40 centers with the overall complication rate remaining about 5 to 6%, with the TLR and of course the MACE rate of 10% in these complex cases. So clearly we have done a lot as a country to advance this field of the CTO. Now there are a few other issues, which is the retrograde recanalization, which is being done now at many centers. And what it has done is it has added little extra in terms of the overall success of the intervention. Retrograde is done in about 15-20% of cases, but it has added to the overall success and, of course, sustained benefit. People always ask, if you have a collaterals into the CTO, Is it going to make a difference? We actually have a paper to answer that patients who have CTO with a well-developed collaterals, which is the Rentrop 2 and 3, that you do a medical therapy versus do CTO recanalization, you really improve the overall outcome, which we have learned that patients with successful recanalization do better on long run. And of course, this is our European registry, UK CTO, that successful revascularization improves the overall survival at follow-up. And we have many of the randomized trial. In next 2-3 years, this field will become a little clearer. Issue about how should be the optimal depth duration post-PCI. We know that many trials have been done. If you exclude the depth trial, the basically message is that shorter depth has equivalent MACE, longer depth had higher bleeding, no difference in stent thrombosis. Although longer depth, there is some signal about higher cancer rate, although not as an individual trial. Remember the depth, which was my top one advancement last year. After DES and after BMS, clearly the long-term depth, which is the red, always have a lower event, almost 2% lower, not 1% by the stent thrombosis, 1% by additional myocardial infarction of the native vessel, whether DES or BMS. And same thing is also, people say maybe with everolimus eluting stent may be different, but it's about the same, as you can see, that lower event rate, lower MI with the 30-day depth, 30 months depth. Now, we actually have published the data from here, that from Mount Sinai with the overall the trials data, that first versus second generation, it turns out to be the longer depth is more important for the first generation, which we don't use, compared to a second generation in this meta-analysis. So to answer this question further, 12 versus 48 months, the trial was actually stopped early because of low recruitment. But overall, the message in about 1,400 patients, we learned that there was slightly lower event rate with the extended depth group compared to aspirin after 12 months. But overall, individual endpoints were slightly lower with extended depth, but did not make any significance, as you can show here in this slide. Then, of course, these are the long-term data, which is beyond 12 months, and seems to be that if you combine all of them and largely driven by the depth, that you have the positive for the favors long-term therapy. So question is, should you continue long-term? And I know that, which is not part of this symposium today, which will be next year, that recent guidelines have truncated the depth for 6 months in the non-acute coronary syndrome and acute coronary syndrome to 12 months. But we know that some subgroups do benefit for the long term, one of them being the myocardial infarction and the patients who are on diabetes. So clearly you can see this is from VA, large number of patients. So diabetic on insulin or diabetic on not insulin, that continued death and myocardial infarction, whether particularly with the DES, is lower with the long-term continue more than 12 months versus less than 12 months. So event goes down less when 12 months further, whether insulin or non-insulin for death and myocardial infarction. So clearly one group, diabetic, probably should continue longer. Second is this another meta-analysis of the MI patients, clearly that all seems to be lower event rate, patients for extended depth, those who have myocardial infarction. Of course, the trade-off is the bleeding, as shown here. So now the field actually still evolving. We don't have a final answer. One of the issue remains is long depth is okay, but then you have a higher bleeding. How can you take care of this issue? Is that let's stop the aspirin, particularly when you have a stronger antiplatelet therapy. And that is now with the global leaders trial, 1 month aspirin, or with the Twilight, which Roxana Mehran is the national PI for the ticagrelor, is stopping the aspirin after 3 months versus continuing. But everybody gets ticagrelor, single drug, after 3 months. So clearly this field evolving, and we'll hear more in the future. We actually also have the editorial in the JAC about that. Clearly, the balance of the bleeding and the stent thrombosis is when the patient is presenting. Very early, that we know that it's the myocardial infarction more important. Once you go away, after 1 year, 2 years, 3 years, it's more of the bleeding. So clearly that in a short term, we know that you have to prevent the event, so need to continue, but long term, probably it's the bleeding which takes over. So what is my recommendation? That now, clearly that patients who are even less than 6 months, we should continue antiplatelet for 6 to 12 months. Now, of course, with the guidelines become 6 months, but maybe some cases even less than 6 months, particularly with the non-cardiac surgery need and high bleeding risk. And where do you continue longer? Whether it's a 1 year, 3 year, or lifelong, is patients with a prior MI, diabetes, or those who have thrombotic event and very complex PCI. So then issue remain that what about continuing the stronger antiplatelet therapy, which we know with the Charisma, with the clopidogrel was not effective, but in a Pegasus trial, because Charisma basically patients with the MI had a better benefit of clopidogrel in those kind of primary and secondary prevention. So Pegasus TIMI 54 made it because of cardiovascular event in patients prior MI with ticagrelor compared to aspirin. And of course, ticagrelor used 2 doses, 60 and 90 milligram, and basically showed that compared to aspirin alone, adding ticagrelor, you decrease the event rate, primary endpoint at follow-up at 3 years. Now, question comes 90 versus 60, and that's a very bad issue that you can see here, no difference in the 90 versus 60. These are the patients who have MI more than 1 year ago, or may have, many of them had stents, but what it did is that no difference in the dose, but you definitely start decreasing the bleeding. So it makes sense that after 1 year, if you need to continue, you can go to a 60 milligram dose, and that will be beneficial, and that really has changed our practice at present, and various side effects which we know are ticagrelor related. Then question comes this field of the full revascularization versus a culprit vessel with the initial 2 trials of the PRAMI and culprit showing the red bar, lower event rate in the complete revascularization group. Now we have extended this field further, that what if you do complete revascularization based on the FFR? That is what the standard of practice now is, which is the Dynami 3, about 600 plus patients. So basically you do an infarct-related PCI, you have outcome at 3 years of 22%, primary endpoint became just about 60% down to 13% if you do complete revascularization based on FFR during the same admission. And this is the individual breakdown. It's all dependent on the urgent and non-urgent revascularization. So basically, FFR is determining the patient who is going to get sick, so you do a PCI at the time. Of course, these 3 trials have really shaped this field, and we actually have an explanation in our editorial in the JACC intervention with my fellow that 2 years ago, that why this makes sense. Because in STEMI patients, the non-culprit, while PCI during stable syndrome is not an issue, but in the MI issues, because of the systemic process of increased coagulation, inflammation, endothelial dysfunctions, and so. And therefore, best sealant, not the medicine, it's the stent, which really prevent the future events. And of course, what it has done, it has changed our guideline of the complete revascularization from 3 to 2B, and hopefully soon, with this trial of Dr. Yusuf, with a complete, will answer it, may become class 1. That complete revascularization is the better approach in the STEMI patients. Then question comes that prediction of imaging in the peri-procedural MI, because we have the IVUS, radiofrequency IVUS, then OCT and NIRS, and they all can have determined various factors which can give rise to peri-procedural MI. And these can be, they're available in every lab, and if you image these lesions, and a lot of them will be done today, that you can identify which lesion could give us trouble. And this is basically the issue, is that can you identify by the imaging you become a safer operator. One is you have a good stent expansion, but second is, can you identify lesions which are going to give peri-procedural MI? So you could be more aggressive in terms of treatment with the stronger P2Y12 inhibitor, or with the 2B3A inhibitors, and so forth, or change your strategy. And this basically, the study shown in stable patient that the lipid core burden index is the 600. So 600 was the median to create, or which caused predicted the MI versus no MI, and that led to the basis of the Canary trial, that patients with a 600, more than 600 LCBI were randomized to PCI with filter. Thinking that this lipid is embolizing, you put an easy filter and capture that embolic material versus PCI alone. And of course, patient at PCI with less than 600 LCBI without being randomized in the trial. Trial was very truncated, but basically what we learned is that if you use a filter, did not make any difference in terms of reducing MI. So therefore, just like earlier trials have been done with a distal protection device, in a native vessel, filter has no role, even if you have a large plaque burden or lipid burden, which is defined as a 600 of the lipid core index. So what we learned basically, that patients who had MI did have a higher lipid core burden. but it did not make any difference in terms of the catching it by the filter device. So, and of course, the plaque burden is higher in these patients and lipid-rich plaque. So then, they mentioned that yes, the lipid core is associated with the MI, but by reduction of the MI could not be obtained by using the filter device. So from our center, under Dr. Keeney's direction, we published 110 patients who had OCT, IVUS, NIRS, pre-PCI. Just to understand this, that what this multimodality intravascular imaging can help us to identify the patients. And clearly, the patients who had a CK elevation or troponin elevation and did not, we have divided them, which occur in about 10% of cases. And basically, that patients who have a more CK elevation had a higher minimum cap thickness, means thin cap fibroatheroma is much higher in those cases. And the overall 90% versus 20%, and of course the lumen cross-section area on IVUS, and same thing on the NIRS, that patients who have MI had a higher the lipid core burden index compared to those who did not have myocardial infarction. But then we really needed to understand which of these three modalities is important. It turns out to be in the multivariate analysis, it's your cap thickness. On OCT was the strongest predictor of the myocardial infarction, and then if you exclude the cap thickness, OCT if you exclude, then only your lipid core comes in. So see that, and exclude OCT on the right side. So your lipid content comes in only after you exclude the cap thickness. So the thin cap fibroatheroma by our 110 consecutive patients is on the top, followed by the NIRS, and then of course with the IVUS plaque burden. So clearly this field continue to go forward, and maybe we'll try to make some points today during imaging during PCI. Then question comes that all the trials in the past have been done with the Texas, and so with the syntax using the Texas DES, which we know that associated with the higher event rate with the increasing syntax score, but that was the first generation DES compared to CABG, and same data at a 5-year in the high risk, that you have a lower mortality with the CABG compared to PCI, and similarly in the Freedom, lower mortality, about 5-6%, similar to high risk of the syntax, but again using the first generation stent. So what about the newer generation? And actually, we have one clear example of the Tuxedo, India, in a diabetic patient, large number of patients, Texas versus Zions. And you can see here, event rate became half. So you can imagine if you would have done with the second generation stent, the trials of syntax or Freedom, maybe the event rate which occurred in the DES arm would have been half. But same also significantly lower stent thrombosis as well as myocardial infarction. So this is again hearsay, although we don't have a direct comparison of the newer devices, newer stents in the trial, but we have some data. One is the everlumus eluting stent versus bypass surgery with the BEST trial, and showed basically, although trial was stopped because of poor enrollment, but showing one very important issue. PCI versus CABG at about 3 to 5 year follow-up, that now the death difference was no longer significant. It still have slightly higher with the PCI group. Of course, the myocardial infarction a little more, but overall, it seems to be a little better outcome than what we learned in the syntax. The second is from the New York State, by Bangalore, the data of the everlumus eluting stent versus bypass surgery for multivessel CAD in a large number of patients, case control of 10,000 patients each group, showed again the same message, that by using the newer stent, everlumus eluting stent, that there's no difference in death. Of course, you have a higher MI rate, and you have higher revascularization. And with the CABG, you have a higher stroke rate. So seems to be one of the big with enigma was that particularly in the patients with the DES, you have higher mortality. Seems to be with the newer trials, with the newer stents, that we are not seeing it. Now, what about in the diabetic patients, which was the Freedom comparison? And you actually showed in this study, again from the New York State, that on the short term, the ES was better than CABG because of lower mortality, which we all know. But more importantly, on the long run, again, now there is no difference in the death, but myocardial infarction is more. So seems to be that even in diabetic, in this study, not a large number of patients, but from the New York State, where every case is very censored and monitored, that overall mortality at 3-year follow-up was not difference with the everluminous eluting stent in the diabetic multivessel versus CABG, but yes, MI and revascularization higher, and of course stroke higher in the patients with the CABG. The final answer will be in that this year's TCT, the Excel trial, which has randomized about 1,800 patients to left main and multivessel disease to everluminous eluting stent versus CABG, and we really stay tuned to answer that yes, in the modern era with the randomized trial where we are. Then question comes, is the patients who have developed restenosis in stent. We know that even with the DES, you have a lot of in-stent restenosis. It's all mediated by intimal hyperplasia. There are numerous techniques which are available besides patients being sent for bypass in terms of re-PCI, and a lot has been written about drug-eluting balloon. Just to mind it, drug-eluting balloon is not available in the United States for the in-stent restenosis of the coronary arteries. It's available for peripheral, and earlier data showed that when you compare with the PTCA, drug-eluting balloon did better, which is the red. The overall event rate of the various trials showed that it's better than conventional, which is the PTCA for in-stent restenosis. And of course, the ICER DESIRE 3 trial, this is the paclitaxel, this is the eluting balloon, this is the stent, and then of course the conventional balloon angioplasty. So overall, it seems to be that your drug-eluting balloon do good in the short term. Question was in the long term, particularly against the more important, the newer stent. And this actually has been shown by the RIPS trial. 4 is for the DES and the RIP 5 was for the BMS, showing that if you compare your drug-eluting balloon to everluminous eluting stent, which is the second generation, your outcomes are better with the EES compared to drug-eluting balloon. So clearly now, with the DES ISR, the treatment is another new generation DES, rather drug-eluting balloon. So this is for the BMS, similar message. Because the data actually have come up now that with the long late restenosis with the paclitaxel coated balloon, it occurs in the patients at late follow-up. So it's kind of a catch-up phenomena. So this basically is that, is it because of the drug? We know the paclitaxel is not a good drug in terms of inhibiting restenosis, so that a lot of other data, the trials are ongoing at present using sirolimus or other combination of these drugs. One of the answer could be, so this is like Colombo is a drug-eluting stent, the default strategy for drug-eluting stent restenosis, where he emphasized that maybe vascular scaffold, BVS, could also be the answer for many of these patients. Then question remains, the major trial was done, Matrix, which answered 2 questions. Whether transfemoral is better versus transradial is better than transfemoral, or what about bivalvulotin, because we have a lot of controversy in this acute coronary syndrome versus heparin. So basically, we knew that horizons, that bivalvulotin was associated with a lower mortality, lower bleeding rate, and recent trials which were done had various conflicting results, but majority of them showing no benefit, which really has decreased the overall use of bivalvulotin in United States from 76% 2 years ago to about 40% now. But the matrix was the very complex trial design, but really answered many of our important questions. One is transradial versus transfemoral, and then heparin versus bivalvulotin, and then whether bivalvulotin should stop the infusion after PCI or you continue for up to 6 hours. Very complex design. But overall message that bivalvulotin versus heparin, you see the height of both the bars are identical. Somehow there is still a little lower mortality we can't understand. Maybe it's again mediated by lower bleeding. So MACE point of view, none, no advantage of bivalvulotin, but clearly caused lower bleeding, maybe that's caused lower death rate. But overall, this actually has kind of sealed the overall concept, everybody's belief that bivalvulotin is no longer superior to your heparin, particularly if you have used the stronger antiplatelet therapy. Then second important question was transradial versus transfemoral. So clearly you see here, transradial again came superior in these patients with acute coronary syndrome and MI, that lower event rate with the transradial compared to transfemoral, and again could be mediated just by bleeding, and also lower mortality. So this is addition to our earlier trial of rifle stacks, and so showing that transradial is superior to transfemoral, particularly patients with acute myocardial infarction. This is the meta-analysis published in Annals of Internal Medicine, just showing that clearly lower bleeding and the lower mortality, which has changed the guidelines now, actually in Europe. 1A in acute coronary syndrome, September 2015, although United States is still lacking, but hopefully should be available soon, update on this transradial intervention. Then question comes, the TAVR versus SAVR in low-risk patients, which is the NOTION trial. We know that two approved devices are being used very frequently in patients with the high risk and inoperable risk. And of course, the NOTION trial basically was randomization of the patients with a low risk to the core valve TAVR versus surgery. And these patients have a low risk, about 300 patients. You can see STS risk was less than 3, which we define as low risk, and basically showed that overall at 1 year, that non-significantly lower mortality with the TAVR, which is the in blue compared to red, and as well as stroke. And this is basically continuation of what we have with the recent trials of the TAVI and TAVR in this field. Basically that showing that every risk group, the TAVR is coming superior to SAVR, whether statistically or non-statistically significant. Now, more important is, these are the various endpoints. Of course, only problem is the pacemaker issue, that you have a higher pacemaker rate with the TAVR in this group. So what has happened? The field has evolved, that patients with the high risk and extreme risk getting the TAVR, some of the trial, this trial, NOTION, is one of the trials which showed that even in low risk is better. And as you know, that now we have partnered 2A data intermediate risk, which is superior, was presented this year in ACC, and hopefully will become the clean approved by FDA soon. CERTAVI just getting completion of the core valve versus surgery in intermediate risk patients. So clearly that now the TAVR is really getting the momentum at present. And of course, patients, even with the who are operable, but if they are high risk for surgery, are getting TAVR at present. And that actually has led to the overall number and growth of this procedure. The TAVR procedure with some decrease in SAVR, but cannot be explained by the TAVR growth. Why? Because many of those patients were sitting, were not getting any treatment, now undergoing the treatment of their aortic stenosis, and this is our data, 201 last year, with a 56%, overall about, we use more core valve, so as you can see here, about 75% or 80% and about 20% sapient. And key is, half of them under conscious sedation, majority of the femoral because of the catheter size has become small, and then many cases we do with the subclavian, and these are our 30-day outcome. This year already, as of this month, we are at a speed of crossing the 300 number, because we already like 145 plus that in first 6 months, so clearly the TAVR volume continue to increase. So then come to the most important and top advance of 2015, number one being the data, our ABSORB trial. ABSORB, particularly the ABSORB 3, comparing the bioabsorbable vascular scaffold versus metal DES in particularly non-complex PCI, with the concept that this the polymer and polylactide will undergo degradation. So over time, the vessel will become stent-free. So there will be no metal, so we undergo through normal physiological vasomotor function. More important in the younger patients, and that is where you can really get to the good activity of the patients, and has shown that really you can disappear that stent at 5 years. You see nothing in the artery as shown by the OCT, compared to metal always stays there. So key is that removing this metal cage, initial data, again, we are going through this process of any new technology. You have a data, some which good, some bad, but clearly to understand where the problem is, these are the 2-year data of the ABSORB that showed that yes, okay, but you still have kind of a little inferior outcome. And most important is the stent thrombosis with the ABSORB. And this led to the presentation, which is our advance number 1 in the ABSORB 3 trial of the 2-to-1 randomization of 2,000 patients, ABSORB versus Xience, and clearly showed, again, ABSORB in yellow and Xience in blue, that yes, it may not be superior to our 5th or 6th generation DES Xience, but came non-inferior. So whether it's a good or bad, it need to be, sometimes you need to trade off some early loss for the better future. And better future is the stent will disappear in 2 to 3 years. And clearly the one big issue remains is the device thrombosis. And now a lot has been done now to understand that why this occurs, and actually a lot of data now is that you follow a specific absorbed deployment protocol, that number becomes similar to your current generation DES. But again, it needs to be seen in the randomized trial. So overall, it's a stiff stent, and of course cause a little more MI because of thicker struts. So more change will occur to get a thinner struts. One of the important things which has come up is the small vessel size. If the vessel size is 2.25, you have a higher stent thrombosis compared to giants, and if you're more than 2.25, it's identical. And same thing is for the target vessel failure. So we learned that in a smaller vessel, the absorb is not the stent to scaffold to be used. So only for the large vessel and so. Angina issues and other points were not different. So then we have the data from Absorb China, similar kind of message. Absorb Japan, there is no difference in stent thrombosis. Why? Because everybody in the Japan, 84% patients get imaging during PCI. So maybe that will be the key. And of course, in the STEMI also, in terms of healing parameters, that was better with the Absorb compared to everolimus eluting stent. And you know the FDA has approved it. Hopefully within next 1 month, we'll have the Absorb in our hand, and we all has to come up with the protocol, which patient to use and how to use it, and use it safely so that we don't get our setback. So there are many other stents, the Dissolve, Biosol, Phantom, all are being studied at present. On the same point where the biodegradable stent is going on, or bioabsorbable, we also have a data, as you know, on the biodegradable polymer of the synergy with the EVOLVE-2 trial, and it's basically showing that very important issue that yes, although they were identical, there was non-statistically lower stent thrombosis. But what we are learning now is that after 1 month, that with the synergy stent, there is no stent thrombosis for 2 years. So that's a very, very important observation. So clearly that biodegradable as well as the absorbable, biodegradable polymer, bioabsorbable stent are the future for our intervention cardiology, which will decrease also the depth dependency. So basically, these are our top 10 advances. And the purpose is, if I had to sum up, bivalvular distal protection device in the high lipid contents and drug-eluting balloon, no, negative. Prolonged depth, ticagrelor long-term and Absorb, yes. Absorb 3, I would say, kind of plus minus, people are still concerned, but overall FDA even felt that this is the device should come. Then CTO PCI, FFR, guided multivessel PCI in STEMI, newer DES for multivessel disease, really 2 thumbs up. And the real, I would say, is the tower in all risk patients and TRI in acute MI patients really made a big, big difference for 2015, and which is becoming our standard of practice for the better interventionalist. So just to sum up, some of the data from Mount Sinai Hospital for last 5 years, these are all complications. Every patient is very carefully tracked. For the in-hospital death, about 0.24%. No patient of the 3,700 went for emergency bypass last year, and overall complication rate remain about 0.6%. And we have compared it to data of other institutions. The last report is from 2012. So we not only enjoying the great volume, but more importantly, doing the great job with one of the very low 30-day risk-adjusted mortality. If you are statistically lower, then you get a double star. For 2012, as you can see here, very few centers get the double star, although there's such a small number of the event. But overall, you still make it with the higher volume and lower complications, really is a great thing to do.